A young person in their late teens presented to me last week and said that they'd had pain in their knee that had becoming increasingly progressive for a long period of time. And they'd been told by their general practitioner that they couldn't have osteoarthritis because they were too young. Unfortunately, particularly in the context of increasing numbers of people injuring their joints, as well as increasing numbers of people who are overweight, we're seeing an increasing number of young adults presenting with osteoarthritis. This isn't just a disease of older adults. 2/3 of people who are affected by this disease are under 65, and a substantial proportion of them, about a third, are under 50. As mentioned, because of increasing numbers of both joint injury and body weight changes in the community, this is going to continue to occur for the foreseeable future. It has massive consequences for the people involved because they then have to live with this disease for much longer. So both in terms of the symptoms that they experience, the quality of life, the impacts that that has on their mental health, but in particular, one thing that we often don't talk about is the economic impact, particularly as it relates to their employment. So there's an important message to get across about recognition, about management, and about proactively empowering those younger people who are living with this disease to do a lot more about modifying the lifestyle and other things that they can do to mitigate against the disease. So it's that topic about younger adults living with osteoarthritis, and this not just being a disease of older adults, that is the focus of today's conversation. And we're privileged to have Anthony Perruccio, an associate professor at the University of Toronto, to talk to us today about this incredibly important topic. Hello, Anthony, and welcome to the show.
Thank you, David. It's a pleasure to be with you.
Thank you so much for taking the time. I know you've had a busy week. So in the first instance, can you just share with the listeners a little bit more about your background and what a typical day looks like?
Yes. I have a PhD in epidemiology from the University of Toronto, and I undertook postdoctoral training at the Arthritis Center for Outcomes Research in Boston. Now I am a senior scientist at the Schroeder Arthritis Institute in Toronto and associate professor of clinical epidemiology at the University of Toronto. Typical day. I'm not sure I have a typical day. Some days are largely taken up by administrative work. Committee meetings earlier this week, entire days devoted to funding application review panels, teaching certainly as well. Other days are devoted to research, which can mean analyzing data, overseeing and providing input or mentorship to a number of projects within our research unit, writing, and then having discussions with colleagues about study results, next steps. Most days, it's a combination of all of the above. I haven't developed a habit yet of blocking off ahead of time for writing and thinking, and time spent on administrative, non-research work can easily overtake a day. So that's the typical, non-typical.
Yeah, it sounds very similar to my lived experience, but just out of personal interest, you juggle a lot. How do you prioritize what comes first?
Oh my goodness. Whoever is screaming the loudest, I think. Or whatever is due tomorrow or the following day. Writing is important, and many of us are judged by that. So writing has to take priority, although it's probably the thing that I set aside the most because there are just so many other things that are put on the plate. Wow, I don't know. It really is what is most pressing is probably what takes priority.
Yeah, I hear you. And I hear the complaints about timelines and deadlines and not meeting them. So fully aware of your lived experience. Now, Anthony, when you're not at work, what do you enjoy doing?
I do enjoy reading legal thrillers. John Grisham is probably a favorite author in that space. I think part of the appeal is trying to put together a puzzle from so many details, some of which may be important, some which are not in the end. I suppose that's what we do as part of our work as well. It's always trying to piece together a puzzle when we don't often know what that puzzle is supposed to look like, what that picture is supposed to look like. I'm not quite sure what the attraction to the legal part of it there is. I can tell you that in my probably early 20s, if I wasn't at school or if I wasn't at work, you would probably find me sitting in a courtroom, listening to and observing criminal cases. I don't recall how that ever began, but I certainly remember enjoying it. So yeah, certainly easy for me to pass the time reading legal thrillers.
Did you ever have something in Canada called like a mock review or a mock panel where they essentially tried to mimic what was happening in the courtroom during school?
So not as part of any of my training. I never did anything related to anything legal, but I would go to the two law schools in the city to watch the law students during those mock trials. Oddly enough, I never did anything career-wise legal related, but my older brother did. So I don't know what all that was about.
Oh, sounds like you had an inclination that way. Now, just back to the puzzle for a second. When you were referring to the puzzle, was that related to your clinical work, to research?
Yeah, it's to the research. So I'm not a clinician, so I don't spend days with patients, although I do have the benefit of working in a hospital. And so I spend a lot of time with orthopedic surgeons, rheumatologists, plastic surgeons who work on the hand side for osteoarthritis. So I have been in clinic to hear what patients say. And the piecing together of the puzzle often is piecing together the data that we have collected from patients and piecing that together with what I know from the epidemiology of the disease. So it's not always the case that people that are being studied in a research study necessarily reflect the group of people out there in the population who have the disease. So it really is that piecing that together is often the tough part, I think.
Yeah. No, I like the analogy to a puzzle. Both myself and a close colleague who I've had on the podcast enjoy puzzles in real life rather than,
And I do.
oh, you do as well.
Yes, absolutely do. Yes.
Wonderful. Anthony, if you had to describe yourself in 5 words, what would they be?
The first one would be introverted. I do like being alone with my thoughts, reflective as well. And that may be tied in to being introverted to some extent. Certainly curious. I'm always curious about how things work and why it is that they work that way. That's always been the case. There are many things I remember, and my parents will tell me as a child, taking things apart, trying to understand, how they functioned. Persistent is probably another word. I will keep at something until I have understood it, or at least I think that I've understood it. And that is definitely true in the work that I do as well. Last one, probably patient. I think I'm naturally a patient person, a quality I suppose you need to have in research as well, since it can take sometimes years to figure out that puzzle. So I think patience is a needed quality for the type of work we do.
Yeah, all tremendous qualities, and I'm sure you've applied them wonderfully well to your life as a researcher. Again, a question more out of personal interest. One of those qualities was reflective. In today's world where noise is coming at you from all over the place, how do you find the space?
So there, you know what? I really enjoy the early morning before the rest of the family has gotten up. I absolutely love sitting on the couch, having coffee. And for anyone else, if they saw me, they would think I was staring into space. But those are the times where I can just quiet down everything else and devote the time to think about what needs to be thought about or what I want to think about. On the couch, often drinking coffee are those times.
Oh, look, thank you so much for sharing that, because I don't think we value the opportunity to pause and reflect enough. And it's so important.
I agree. I do agree. Very much so.
Yeah. All right. Now, before we digress on and talk about reflection for the next 20 minutes, let's get into the topic at hand. Obviously, this is an incredibly important area, particularly as it relates to younger people experiencing and living with osteoarthritis. But I guess in the first instance, can you just tell me a little bit about why people develop osteoarthritis as sort of a prelude to the next conversation that will hopefully happen?
I'll identify some risk factors for the disease, and then I'm going to backtrack a bit and sort of come back to that. I mean, we certainly know that age is a strong predictor of disease, sex as well. So females are more likely than males to develop the disease. Having said that, the prevalence is high in males and females, but the risk is greater in females. We certainly know that excess weight or high body mass index can be a risk factor. Maybe I should clarify, that's probably more so for knee osteoarthritis, hip as well, perhaps not so much for the hand. There are certainly genetic components to the disease as well. Prior joint injury. So individuals who injure a joint, about half of them will go on to develop the disease on average. Muscle strength, or I should say muscle weakness, as a risk factor. Weak muscles often can lead to unstable joints, and unstable joints can lead to either disease or, if not the onset of the disease, maybe the progression of the disease. So having said that, I'm going to backtrack if I can for just a moment. When we identify those as risk factors, those are risk factors for osteoarthritis as we currently define it. And often, I think how we define osteoarthritis today, and I'm thinking, radiographic imaging, most believe that the disease is well established by the time it meets our current definition of OA. I'm also going to say, so keeping that in mind, I think most of us recognize now that the disease is heterogeneous, that there are probably different subtypes of disease, and that each of those subtypes may have their own mechanisms. It may be that all of those mechanisms, the end result is what we define as OA, so that the risk factors that I just mentioned may be either the risk factors that are common to all of those mechanisms, or may be the set of risk factors for that mechanism that is most prevalent. So it may be that the risk factors for each of those subtypes of disease can be quite unique. So the ones that we know from epidemiology may be common to all of them, or may be the ones that are most prevalent. I suspect each of those subtypes have their own unique risk factors.
Yeah, it's a great way to look at this because there's a lot of conversations going on in the community about both better ways of defining the disease, but also in particularly at subtypes of people who are developing this through different mechanisms. Now, please feel free to use whatever definition of disease you're most comfortable with. But when does disease typically develop?
Oh, no. $1,000,000 question. I can tell you the average age that it's diagnosed. So from the study that we did, average age was about 50. With that said, about a third of individuals are diagnosed before the age of 45. So I think often when we talk about averages, we miss a lot of that earlier age. So about 1/3. The interesting thing, and it relates a bit to that early disease that we were talking about, and I think an important finding. For those individuals that said that their joint symptoms began at the age of 65 or later, often they received a diagnosis within a year. So from symptom onset to diagnosis, about a year, if they were age 65 or greater at the time that the symptoms began. For those individuals that reported that their joint symptoms started at the age of 35 or earlier, the time to diagnosis was nearly a decade. So by the time they were diagnosed, they probably had the disease at that point for 9 to 10 years. And so this is why, getting back to my earlier point, by the time we diagnose it, the disease for many, I think, is already well established. Now, there's a problem there. If it's taking 9 to 10 years for these individuals to get diagnosed, then we have to consider that, we don't have a cure for the disease yet. So that means these individuals are living with disease 30, 40, 50 years. And given some of the other findings from the study, that's a long time to be living with symptoms and to be living with disability. We're clearly missing it for younger individuals with disease.
Completely agree. Now, is that a limitation in our diagnostic methodology with regards to time it's taking to do that? Is that people who are just not presenting and living with those symptoms? What is that?
Yeah, fantastic question. And I can only speculate. I think that osteoarthritis is largely perceived as a disease of older age. So for younger individuals who develop joint symptoms, I think for some, it's not even a consideration that they could have osteoarthritis. Well, that's not even possible. That's for older people, right? So I think it can be just dismissed. And why would they seek care if they don't think, it could be that? For others, I think it may simply be a lack of knowledge about OA risk factors. If they have those risk factors, but don't know that those risk factors are tied to disease, again, they may overlook that. The other may be simply not being aware that there are things you can do to help yourself with the symptoms, potentially mitigate the progression of the disease. So I think from that perspective, they probably are not going to see a healthcare physician. Because of that, they're not being diagnosed. Because of that, from a population perspective, I think there's a big underestimate of disease prevalence in younger individuals. Then from the diagnostic side, I will highlight, by way of example, the American College of Rheumatology criteria for hip and knee actually have in there, as one of the criteria, over 50 years of age. So I think for some physicians, it may be simply a reluctance to use that diagnosis for younger individuals, or for some even not having the awareness that the disease may in fact be prevalent for individuals of younger age.
Yeah, great points. And, it really highlights the challenges that we have with our existing methods of defining the disease and being wedded to methods that were developed decades ago. There, I'm particularly thinking about the radiographic diagnosis that we really, really need to improve upon. And again, just to highlight that really important point that Anthony's making, is that this isn't just a disease of older adults. Both Anthony's study and others have suggested about 2/3 of people are of working age, so under 65. And a substantial number of these people are under the age of 50, which by the existing definition doesn't necessarily meet that. So the consequence of that, obviously you've got people who are less than 50 who presumably are living with this disease for longer. What impact is that having on those people?
It was very interesting. We had sought out to look at the impact of the disease amongst younger individuals. We don't have a lot of information for younger individuals. Most OA studies are focused on older adults, and perhaps that's what contributes to that perception as well. We looked at a number of outcomes across the ages for this sample that had osteoarthritis. We looked at the mean number of joints that were affected. Surprisingly, the same across all the age groups. We looked at reports of severe and frequent joint pain. Believe it or not, it was just as prevalent in the younger age groups as it was in the older age groups. It was the same with fatigue. It was the same with severity of activity limitations. Younger individuals were reporting the same level of activity limitations as older individuals. These are individuals with OA, of course. The extent to which osteoarthritis affected their lives, the reporting of moderate to extreme effect was the same for younger individuals as it was for older. So if you looked at the disease from an outcomes perspective and the impact it has on people's lives, you would never know if they were older or younger. The outcomes were the same. And there are OA researchers that may not realize that. And imagine the public, how much more they simply do not perceive that being the case. And I think that's problematic for individuals living with the disease, for the healthcare system, for health system planning. I think that's a problem.
Yeah, no, it's a huge problem. So you've got this large group of people who are living with symptoms and the severity of symptoms for many, many years. What influence is that having on their overall health and mental health and their life satisfaction?
So individuals were asked, how do you view your overall health? How do you view your mental health? And they were also asked about satisfaction with life. In this case here, we compared outcomes for individuals with OA to counterparts of the same age in the general population. For older individuals with osteoarthritis, they reported poor health, poor mental health, and life dissatisfaction, pretty much to the same extent as older individuals in the general population. It was within the younger populations that we saw quite a difference between younger individuals with the disease and the general population. So, proportion of people reporting poor overall health. Amongst younger individuals with osteoarthritis, they were 5 times as likely to report poorer health than their counterparts in the general population. 4 times as likely to report poor mental health relative to their counterparts in the general population. And then 6 times higher to report being dissatisfied with life than their counterparts in the general population. That's troubling. It's troubling because those are outcomes that can also be associated with other health outcomes over time. And to think that these are the very people that we're often overlooking clinically and in research, these are big impacts on their life. And these are younger individuals. So consider that many of them are at the peak of work life, at that age where they're raising families, and there are young kids in the family as well. And we're talking about individuals that are reporting severe and frequent joint pain, severe and frequent fatigue, poor night's sleep associated with their osteoarthritis as well. And it's a problem we can't ignore. It's a problem we should not ignore, both in the clinical sphere and from a population health perspective. We also know generally from epidemiological studies that individuals with osteoarthritis are more likely than age and sex counterparts in the general population to have other chronic diseases as well. In this sample here, we compared that as well between the younger and older individuals. Younger individuals were just as likely as older individuals with osteoarthritis to have 3 or more other chronic conditions. Again, not something that most people think of. Oh, more conditions, of course, they're older. No, we're talking about people here in their 30s and their 40s. That's big impact. That's a big impact.
Yeah, I mean, it really highlights the challenges experienced by people living with osteoarthritis for so many years from that early age. I mean, you've really started touching upon this, but obviously in the face of those challenges, we should try to find solutions. So do you have suggestions for what we should be doing differently, whether that be from a diagnostic, therapeutic, or management perspective?
So yes, I mean, I think it's clear to many of us now that depending on radiographic images for defining the disease, I'm being blunt, but maybe that needs to be put to rest. I mean, we know that the symptoms don't always match with what we see radiographically. So clearly that mismatch tells us it's not the radiographs that clearly are pinpointing. Secondly, I think physicians just need to be more aware that younger individuals can have osteoarthritis as well. So I think to shift the focus a bit, younger individuals, reporting joint symptoms, well, don't overlook that. It may be that they do have disease. Probe a bit further. From a research perspective, back to where we started this conversation, established disease versus early disease. We don't know what early disease is. We don't know how to define it yet. And I think that has made it very challenging, one, to identify risk factors for potentially those different subtypes. But I believe that because we don't well understand the disease and its subtypes, perhaps that's why we have had so many challenges in identifying treatments for osteoarthritis. I think we are looking at, any one treatment and applying it in OA. Well, OA can mean very different things. If there are systemic forms of osteoarthritis, well, perhaps that one injection in the knee may be overwhelmed by the systemic features, and so it may not appear effective. So there's a lot to think through. I don't think simply saying OA is enough.
Yeah, no, great points. And I think just to emphasize one of the things you said earlier too, is that a lot of the passivity that clinicians treat osteoarthritis with, particularly in early adults, should be met in a much more proactive way, because there's a lot that can be done therapeutically, and a lot of empowerment that can occur for people who are living with this disease for much longer that currently is unfortunately not happening. Anthony, any final points that you want to make about the paper that you wrote there?
I think I would say this: don't ignore joint symptoms. If you're a younger individual experiencing joint symptoms, or if you have been diagnosed with OA, there are things you can do. For those that, the joint symptoms, you haven't been diagnosed yet, you haven't even thought about going to see a healthcare professional, do it. There are things that can be done. There are many resources, even online. I know Australia has them. We have them here in Canada as well. The Arthritis Society of Canada has a number even of self-management programs that someone can avail themselves of. We don't have the cure for the disease, but you can help the symptoms and potentially mitigate the progression of the disease. So you can feel empowered. Don't ignore young people, and young people don't ignore joint symptoms.
Yeah, it's a great message and really resonates very strongly with the results that you published in this paper. And I think they're incredibly important messages to get out there. Now, just in closing, and it may well be just what you just said, but is there any one piece of advice, knowledge, or wisdom that you'd like to give to people who have osteoarthritis?
So without repeating it, that's one of them that I've already indicated. For researchers, I would say don't ignore younger individuals, because it may be that early disease that we are looking for is right there. And I think even the way we put together osteoarthritis cohorts for study, we may have to start much earlier than you think. They may not have osteoarthritis and may not even appear to have it yet. That's tough. But I think we have to go there. For individuals with osteoarthritis, let me say thank you. And I also encourage you to participate in osteoarthritis studies. There is no other way for us to solve the problem. There's no other way for us to put that puzzle together. We need that big picture. Help us. Let's do it together. Let's put that puzzle together.
Yeah, that's a great way to close. And, obviously a really strong call to people who are out there who are living with disease for many years to get much more proactively engaged, both in managing your symptoms, both with professional help, but also self-management, but also get engaged in research and learn more about the disease and what can be done about it. Anthony, thank you so much for your time, your insights on the impressive body of work that you've accumulated. Keep up the great work.
Thank you so much. It's been a pleasure.
So if you're a younger adult out there who is experiencing these symptoms and you're questioning whether this is osteoarthritis, it potentially is very likely that that is the case if your symptoms are consistent with it. You don't have to be over 50. You don't necessarily have to meet the X-ray changes that are consistent with a diagnosis of osteoarthritis. So please go along, seek help from a health professional, hopefully who will be an advocate for your care and empower you to live with this disease. There's a lot that can be done, and particularly starting with lifestyle and behavioral change. Many of the risk factors that predispose to the disease can be modified and can make a massive difference to your experience of symptoms and potentially the progression of the disease. And there I'm particularly thinking about instituting appropriate management as it relates to weight, doing regular exercise and physical activity to help to alleviate the symptoms that you're currently experiencing. So don't take this lying down. Try to empower yourself with knowledge that can assist you in that regard. So on that note, thank you again so much for your support of the Joint Action podcast. Really appreciate the opportunity to share, hopefully, information that's relevant to you and empowering for you. And between now and when we next have the opportunity to speak, please do take care of yourself.
Thanks for listening to Joint Action with David Hunter. If you like our show and want to know more, visit www.jointaction.info. If you have any questions, you can email us at hello@jointaction.info and follow us on Twitter @jointactionorg. This podcast was hosted by David Hunter, edited by Vicky Duong, music produced by Jordan Hunter. The information posted on this podcast is not intended to diagnose, treat, cure, or prevent disease. Anyone seeking medical advice should consult a health professional.